Thank you very much. Thank you for inviting me specifically for this talk and for this conference. It's really a pleasure to be amongst you. And a pleasure. Last night was excellent. The presentation, the music was beautiful. So thank you again very much for inviting us. The assignment was to have a talk on insulin resistance and concentrated insulin, specifically E500. So I tried to make it a little more interesting by having this definition of insulin resistance and two separate talks. One speaking about insulin resistance definition. What is insulin resistance? What is the meaning? When you inherit type 2 diabetes from your family, you inherit insulin resistance and you inherit beta cell, they're destined to fail. So what is the meaning? What do you exactly inherit when you inherit insulin resistance? And then we'll talk about the second part on what is insulin resistance in terms of the need for more and more insulin as we go on, and what are the reasons for it. So you just have to practice a few couple slides, just showing here that despite all the advances in diabetes, our major concern when we are having problems with diabetes all over the world, not because of numbers, not because we're so crazy and obsessed with numbers, because we don't like the complications that come with diabetes, not only the microvascular complication, we can manage, we can prevent if we control sugar, but the macrovascular part of it is the problem, is we control sugar, but we still cannot control cardiovascular disease. We had some smaller studies showed that it got better, but we were disappointed when we had these larger trials like the Accord, the Advanced, the VA-DT trials, showing that aggressive sugar control did not prevent cardiovascular disease. So what did we do wrong? There's a lot of money was spent on these studies. What was the mistake? Why controlling sugar did not improve heart disease? And what did we learn from this? And what did we learn? And this is prefacing into the talks the rest of the day today, on bypass surgery and weight loss. Why weight loss and bypass surgery can be, as you see the numbers, almost curing type 2 diabetes and some of the other complications, some of the other chronic conditions, where just controlling sugar did not do it. So why is that? Again, more of it. And again, I showed you this a few days ago, why lower A1C is not better. Why it's not a curve that is just straight line. The lower the sugar, the less complication, the less mortality. It was a J curve, which too low of an A1Cs actually cause more mortality, especially if you are on an insulin. So there's probably other factors that affect mortality, quality of life, cardiovascular disease, beyond just sugar control. One of them, it could be just the insulin, hyperinsulinemia. And again, each one of these slides probably will have 100 slides, similar study. I don't want to bore you with all of this, but showing that hyperinsulinemia can be a culprit. There's so many studies for that. Another one would be glucose variability or glucose fluctuations. So maybe you're achieving lower A1C in these trials, but we are doing it on the expense of too many highs and too many lows. That's why glucose variability and glucose fluctuation did not help us protect from cardiovascular disease. Maybe again, this is showing really too complex slide, but it's just showing that because cardiovascular disease is really a big part of inflammation, glycemic variability rather than hyperglycemia is the main culprit for inflammation that leads to atherosclerosis. And we see here also hypoglycemia is another factor by itself. Can lead not only to arrhythmia, because we know hypoglycemia can prolong the QT intervals, and every trial we've done in diabetes, always try with pharma, tried always QT interval is big measurable, we do it all the time. This prolongation of QT interval can lead to dorsal and VFib and sudden cardiac death. So hypoglycemia was also a detrimental factor in improving survival in trials with diabetes. So again, all of these are limited factors to say, again, why just lowering A1C and lowering sugar did not prevent cardiovascular disease. So all of these are possible answers. We don't have to find and say all of them. But what really come to the talk for today is probably the most important factor that will really affect how bad that 2 diabetes is insulin resistance. And insulin resistance is, as we know, some of the associated condition. It comes not only with type 2 diabetes, but well known to affect atherosclerosis, dyslipidemia, and especially dyslipidemia. The increased thrombosis, acanthosis nigricans, probably increasing uric acid, polycystic ovarian disease, which is a very complicated condition that affects a large percentage of the younger population. Impaired glucose tolerance, obesity, and hypertension, all of these come with insulin resistance. But what exactly happened? What is insulin resistance? What does it do? So it is a consistent finding in type 2 diabetes. It's impaired biological response to insulin. And decreased insulin-stimulated glucose transport, impaired suppression of hepatic glucose output. Your word, I'm going to show you a slide to understand it better. One of the ways that we see difference, why we see a 160-pound American Native Indian or Asian Indian carry the same metabolic risk of 210 pounds white Caucasian, the same metabolic risk that a smaller person will carry in the heavier person. Why this ethnic variation? Why it is different? The incidence of diabetes in certain part of the country is different than the other parts. Part of the world is different than the other part of the world. One of the parts is the more insulin resistance you have, the more central fat you have. As you see the difference in the same BMI for these two patients, diabetic tend to have a lot more concentrated central fat, which is an active endocrine organ. Central fat are different than subcutaneous fat. Subcutaneous fat is more of a depot of sugars, but central fat is an active endocrine organ that produces different cytokines and hormones that will affect our risk of cardiovascular disease and diabetes. As we see here, all of these in this corner, plasminogen activated pathway, free fatty acid activated in the RAS system, TNF, interleukins, all of these are factors that play a big role in insulin resistance and also in terms of the cardiovascular complications. This is probably the slide I'm going to spend the most time on. It's a really important slide to understand what exactly happened with insulin resistance. This is the level of the muscle here. This is the muscle cell, alpha subunit, beta subunit. People with diabetes and pre-diabetes have exactly the same alpha and beta receptors. There's no difference. We don't have defective receptors with diabetes. But the problem is post-receptor modifications called tyrosine phosphorylation and PI3 kinase pathway. Eventually, there's 50 steps that will lead to activation of a molecule that is very, very important to help us bring glucose into the muscles to be used, and that's a GLUT4 molecule. Now, why is this important? This is insulin-activated process. So beta cell have to send insulin. So, for example, you just had breakfast. The glucose that you just had is floating around in the blood. First step for it is the muscles. So when it goes to the muscles here, the muscles say, I want some of that glucose to help me get some energy. GLUT4 is a very important part of that process. It will transport into the surface of the cell to bring glucose into the cell by using insulin. Now, this is where the main problem with diabetes and insulin resistance. We have problem with tyrosine phosphorylation. Again, this is very, very simplifying the process. This is a lot of steps here. But this process is defective. So when it is defective or resistant, the body tries to force this because the glucose is still in the blood and it's still calling, hey, I want to get rid of that glucose. So the body sends for more troops, for more insulin. Insulin comes to the rescue and try to force that process. Now what did just happen? We just forced the beta cell to work 2 times, 3 times, 10 times. That's why in pre-diabetic, we have a hyperinsulinemia state. And it's a necessary step for us to handle glucose. So by doing this, we force our beta cell that, remember, people with type 2 diabetes have also a limited beta cell reserve. By the time you have diabetes, you already lost 50% of your beta cells. So you already have a limited reserve, but you're using it. Just like you have $100,000 in the bank and use it in 2 days or use it in 10 years, it's up to you. You have limited reserve. If you have, any of us here have a family history of diabetes, we have limited reserve of insulin granules and insulin receptors. Beta cells. So by forcing it to overproduce insulin, pushes this process and produce GLUT4, we rush to diabetes and go from pre-diabetes to diabetes. That extra insulin can lead to hypoglycemia, which we know a lot of patients can have hypoglycemia for 10 years before they become diabetic. That's a sign that they have a hyperinsulinemic state. And we test these patients usually for that. And also this extra insulin causes weight gain because the extra insulin will have to get rid of some of their glucose by depositing into fat cells and increase weight. That's why insulin increases weight, by depositing fat cells. One of the other problems this process do also is when you don't have tyrosine phosphorylation, you're forced to go into another pathway. This is the good pathway, this is the bad pathway. So the more insulin produced, the more activation of MAP kinase pathway eventually leads to smooth muscle migration, thyroid activation, plasma activation, so thrombosis, and atherosclerosis. So now we understand what is the link between hyperinsulinemia state, hypoglycemia, or pre-diabetes, and atherosclerosis. We understand why 50% of diabetic at the time of diagnosis, they already have some form of vascular disease. And we understand why controlling sugar does not prevent cardiovascular disease, because sugar is not the only culprit, it is really this hyperinsulinemia. And we have also more evidence that it's hyperinsulinemia, this pre-diabetic. And we're not talking small numbers. I'm not sure of the numbers in Egypt, but in the United States, we have 29 million diabetics last year. We have 86 pre-diabetics. It's a huge number of people. So if in Egypt you have probably 10, 15 million diabetics, you probably have 30 million pre-diabetics. That's anywhere in the world. So these are a huge number of people that we are converting every year to diabetes unless we understand how do we work with these pre-diabetic, insulin-resistant patients to make sure they don't become diabetic. And it's a huge healthcare burden. What also, we're noticing more and more that higher insulin level in these patients, so insulin-resistant obesity, can cause cancer. It's almost, except for lung cancer, every single cancer, and not only incidence of cancer, but incidence of cancer mortality is connected to insulin resistance. 3 years ago, in the United States, the first time, smoking became the number 2 cause of modifiable cancer risk, because obesity, especially insulin-resistant obesity, surpassed that. And that could be so many reasons. One of them probably the effect on IGF-1 with the higher insulin level. Again, there could be more time here. As I said, there's so many other factors when you inherit insulin resistance. So with type 2 diabetes, you inherit beta cell that is destined to fail. You inherit muscle cell that cannot handle glucose very well. You inherit tyrosine phosphorylation that happen. You inherit a process that will lead to more atherosclerosis because of MAP kinase pathway. You inherit a process that lead to hyperinsulinemia, that lead to weight gain and hypoglycemia and increased cancer risk. That's why with more and more obesity, we see more and more cancer. Again, all leads to this physiology at the level of the cells. This is another way of looking at it. Just here looking at another place where you inherit insulin resistance. If you remember biochemistry, which is my favorite in school, not all of you. Now glucose ends up here in pyruvate. Pyruvate goes by a pyruvate dehydrogenase into malonyl coenzyme A and goes in the Krebs cycle. I mean, in order for me to use glucose that I just ate, burn it in Krebs cycle, I have to have pyruvate dehydrogenase, plus all the other enzymes. Insulin directly activates these enzymes. People with insulin resistance Insulin cannot do that. So again, you have to use more insulin, or if you don't activate it, it's going to go in the opposite direction of gluconeogenesis. So instead of getting rid of glucose and burn it, I'm actually making sugar because I did not activate pyruvate dehydrogenase. There's only one other thing that will activate pyruvate dehydrogenase regardless of insulin. And there's only one other thing that will activate GLUT4 molecule at the level of the muscles regardless of insulin, which is exercise. We have metformin that also have evidence that actually activate pyruvate dehydrogenase, either indirectly or directly, but we know it does activate pyruvate dehydrogenase. So metformin plays by decreasing gluconeogenesis. That's why what we see here, with every trial on diabetes, people on metformin tend to do better in terms of cardiovascular disease and cancer risk. So now things will start adding up. Why? To understand these results of the trial, why some will show improvement, some will not. If we go back to biochemistry and physiology, it start adding up and makes sense. It's back to this. That's why here, it's actually in our area in Wayne State, they start using metformin as a primary prevention of obesity-related insulin-resistant cancer because of these data. And we have evidence. We have diabetes prevention program that's been discussed so many times here. There's 1,000 publications on it. But in that, it will exactly show that thing. If we come to these pre-diabetic and we have them diet and exercise, or give them metformin, or another arm give them Breslin, which is taken off the market, we saw that diet and exercise showed 58% reduction in diabetes. And if you remember the MAP kinase pathway that lead to atherosclerosis, people pre-diabetes, when they diet and exercise, they have 42% reduction in the metabolic syndrome. So we decrease cardiovascular effects by diet and exercise. Metformin did not do that, because metformin does not activate GLUT4. And we don't have any drug that activates GLUT4. We only have exercise. This is the problem. Some people think there's a cute picture. They're not. This is my 7th trip to Egypt. Kids 20 years ago did not look like this. Kids now look like this. It's unfortunate change. These kids, when they have obesity that early in stage, and we see it all over the world. I've been in so many 50 countries, and it's the same everywhere. Obesity has been trending. Unfortunately, these kids, because they develop so much insulin resistance, they may have their first heart attack when they're not even 20. So again, going back to put all of this together, you inherit insulin resistance and intestinal beta cell failure. You can become diabetic. All these microvascular complications come from hypoglycemia, but all the vascular complications come from insulin resistance early. Either you can work on these pre-diabetic, who probably may be a billion people all over the world, by better nutrition, controlling obesity, and preventing or actually improving physical activity, we can prevent this from happening. By the time we're here, the atherosclerosis part is done. So if we come with trials like the Accord and say, well, let's bring people here, control the sugar, see, can we prevent heart disease? Obviously we failed because we didn't understand this process. Get you back to this. So if we want to prevent this catastrophe of millions of pre-diabetic becoming diabetic, we want to activate GLUT4. We want to decrease the burden on the beta cell. So one of the factors is we really have to work on the food industry and education and whatever we can to decrease carbohydrate intake. When you have less carbohydrates present to the muscles, we have less of a problem. Second issue, we need to be active in exercise to activate more GLUT4, more molecules, so I don't need the insulin to activate my glucose transporters. I need to do it through exercise. Increasing muscle mass, weightlifting, muscle mass increase showed better results in preventing diabetes than actually diet and a regular aerobic exercise. Because when I increase the muscle mass, you can activate GLUT4. That's why an athlete, a swimmer, can have 30 eggs for breakfast and he look fit. Because he had an engine that burned all that glucose. But what we have happen, some of the Arabic habit, we say, that you're supposed to eat and sleep. And it's one of these older saying that, okay, well, give the time for the food to digest, so you're supposed to eat to go to sleep. That's the worst advice we can give to anybody. You're supposed to eat and be active, because if you're not active, your muscle's going to handle glucose, and then glucose is going to cause all that process. More pressure on the beta cell, an activated MET kinase, atherosclerosis. So not being active not only put us at more risk of diabetes, but also more risk of complications of the heart disease and cancer and all the stuff that comes with it. So again, this slide really, if we understand it well, we can understand how we can prevent this type 2 diabetes. Balanced diet, unfortunately, that's an understanding of a balanced diet. So all the way force people to exercise. So this is the first part of the talk. We'll talk about insulin resistance, the meaning of it, how we can use this knowledge to prevent diabetes, how we can work with our patients. I tell my patients, because people come to us for a quick answer. I want to treat diabetes, give me a shot, give me a pill. But if we go through this whole process of educating about increasing the muscle mass, activate your own GLUT4 molecule, so you can have not only controlling of sugar, because when we give pills, we control A1C. As we said again and again, controlling A1C does not make people healthier on the long run, especially from a cardiovascular disease part and from survival and quality of life. It is really improving all these other factors. So the second part of the talk is the definition of insulin resistance in terms of why we look in trials. When I first looked at insulin studies, the average use of insulin doses were around 20 units in trials. First time I used Lantus around 20 years ago, the average doses were 10, 20. In the majority of patients, we hardly go to 30, and the first few pens will only give you 60 units. But in the last few years, we going from this 50 to 100 to 200. I have patients who take 5,000 units of insulin every day. And we have a large number of these patients. So this other term of insulin resistance, they mean why people require more and more insulin as we go. Why we still cannot control more than 10, 15 units than we started 20 years ago. So many, again, other factors. The injection science. Skin is not made for injection. That's what I tell patients. If you're doing 4 shots a day in the same location, you develop skin condition called lipodystrophy. And you see people most of the time, I say, if I ever know they have lipodystrophy, I tell them, show me how you take your shot. Most people go to the same spot all the time. Despite our education, people don't do the extra effort. They go to the same spot. And if you feel that spot, it has a lot of dysfunction in that under the skin, so it doesn't absorb insulin. That's why sometimes patients inject insulin and they don't see results. That's part of it, because it goes in an area that cannot absorb insulin. So the more injection for a long time, people will notice that I'm going to need more and more and more of it. Lipodystrophy, obesity is a big problem. I have patients who have such a nice obesity that their belly is hanging down almost to the floor. And guess what happened? The lower part of the abdomen, they don't have circulation anymore, but it doesn't hurt. So they love it. When they inject insulin, that lower little piece of fat that is hanging down, when they inject from the bottom there, it doesn't hurt, so they love it. They do it all the time, and they don't realize that it's not going anywhere, it's just going in the skin. And they have to change. Some of these patients come to me on 500 units of insulin. I say, let's all hang in your fat. You start giving it in the legs and switch location, and you see better results. The food industry. Fortunately, the United States food industry controls the world. And everything that changes there changes all over the world. That's why we managed to get China from 1% diabetes to 6% diabetes with only a few McDonald's. The sedentary lifestyle. You look at what kids did 30 years ago and what they're doing now. How much effort we have to do to get our kids to go out and play. They're just sitting in their room playing games all the time. So we have worse food and we have less activity that all lead to more excess insulin resistance. So the average insulin dose changes. One or the other, we were talking about excitement about transplant. The more transplant exciting, transplant saves life by transplanting an organ. The problem, every drug we use after transplant lead to diabetes and lead to severe insulin resistance. That's why we have a whole new disease called transplant-induced hyperglycemia. This is science by itself. It is very difficult diabetes to manage. Steroids have been used for everything. We have people on steroids all their life, they become insulin resistant. And so many other endocrine disorders. So we can go forever saying that the reason why we're needing more and more concentrated insulin. So the use of insulin significantly increase as we go because of these factors. So jumping to this here, that's why the industry looked at this and said, we need to come up with more concentrated. So if I'm giving you 100 units of glargine and 30 units of Lispro 3 times a day, there's no room left in the skin with these higher volume insulin. So the industry said we have to come up with a smaller, concentrated volume, less volume insulin to improve absorption and decrease the lipodystrophy and destruction to the skin. One of these, the U500, has been there for a long time, but we have resurgence. Our center probably the highest use of U500 because of where we work. It's over 600 patients on U500. And because U500 works for patients who need more than 200 units of insulin. And I say we only get the difficult diabetics in Michigan, so we get the diabetics on 200, 300, 500 units of insulin with A1Cs 11-12%. These patients, amazing, when we switch them to U500, we see great results and improvement. It actually works as a replacement for basal and prandial. So you can go from 5 shots a day of 2 basal, 3 prandial to only 3 shots a day. It could be sometimes 2 shots a day of U500. Small volume can get you a much better A1C, and we actually have papers and studies on that. It can be used BID or TID 30 minutes before meals. Can be used with any of these medications, but cannot be used with any other insulin or sulfonylurea. And again, this is for patients, not for everybody, for patients that needed 200 units or more. The benefit comes from the small volumes, of better absorption, and also compliance. You tell a patient take 2 shots a day versus 5, that compliance is much better. Here you just have to worry about the errors. People can be confused between U100 and U500. We spend a lot of time educating patients because of the mistake can happen. But these are not the same. A lot of pharmacies say, can I give 5 times more of this? No, because pharmacokinetics. RU100 is a prandial insulin. RU500 can last up to 12 or 16 hours. So these are not the same insulin anymore. So now it comes in a pen that make it easier. But this is how I tell sometimes insurance, the cover, say, why I have to pay for this? Because you don't have to pay for 10 other. Each vial of U500 carries 10,000 units of insulin. This is how the pharmacokinetics, it works within 30 minutes and lasts around 16 hours, not 24 hours. So you can use TID or BID dosing. We give this conversion chart for people not to make a mistake because it's multiplied by 5. These are the benefits, small volume. But then part of the industry said, well, we need more insulins like this. So now glargine, Sanofi brought this to jail. I'm sure it's available in Egypt, but this is U300. So it's actually just glargine, the same as Lantus, but put it in a 300 concentrate, 300 units per ml, and it showed much better, longer profile, a true basal insulin, less hypoglycemia than glargine. And showing here another insulin that came from Novo Nordisk, which is Degludec, and Degludec showed it is U200 insulin. It has a unique ways of dissociation based on the current level in the blood. So if you give it for people who have a problem with compliance, you can give it at a different time of the day, it will still work as good. You can give it morning, next day at night, next day in the morning, it still will give you because it have 36 hours half-life. Showing less hypoglycemia, way significantly less hypoglycemia. This is the study we did on our population, showed a significant reduction in A1C with not a lot of increase in units, almost 1.4% A1C reduction with the same amount of insulin, not a lot of weight gain within 6 months. And we did the iPro showed that people would go from this to this to this in 6 months on the U500. So again, it's a nice option to use for these difficult diabetics. 18 seconds, so I'm going to stop here. I don't need the slides anymore, but it's just summary. It's 2 parts of insulin resistance. One of it is the concept, what do I inherit if I have a family history of diabetes? How can I work with that inheritance for me, my family, my patient, to prevent them from becoming diabetic? Understanding this at the level of the muscles, understanding that at the level of the liver, understanding the role of exercise and low carb intake, and understanding why we are failing in terms of preventing cardiovascular disease and diabetes because of that physiology. And the second part, the need for higher, more concentrated insulin is there, and industry is catching up to the need of patients. So instead of using that amount of insulin, we'll be using less and less, even less injection because of improved compliance. Thank you very much again for listening to me, and I'm going to take questions.